Okay, the title of my talk may sound quite awkward. Kraepelin and Husserl, an odd pair. I hope it will make sense in about 30 minutes from now. So, Emil Kraepelin, as you all know, was a psychiatrist. He was the founder of modern psychiatric taxonomy. His main contributions has been the so-called Kraepelinian dichotomy between dementia praecox or schizophrenia and manic depressive or bipolar disorder, and of course the gathering of different subspecies of what we consider nowadays subtypes of schizophrenia into the unity of dementia praecox according to the course. I will say no more about Kraepelin, and I will shortly introduce Edmund Husserl, who was no psychiatrist, who was a philosopher. He was the founder of the Phenomenological movement. And we may sum up his major contributions as follows. First, the foundation of the modern science of consciousness, or subjectivity, and the establishment of the concept of life world, of Lebenswelt. I will not go into details because I will try to explain this concept a bit later. So the point is, what do they have in common? Why do I bring them together in my talk? As you all know, scientists, philosophers, and intellectuals, and human beings in general can be divided into two main categories, lumpers and splitters. So the first thing that these two men have in common is that they are both splitters. Yet there is a trend in contemporary psychiatry to use quite a lumper-style concept, the concept of psychosis. The concept of psychosis is used as an umbrella term to include several syndromes that were kept separate by Kraepelinian taxonomy. The question is, why? Why do we use the term psychosis? Do we use it on the basis of scientific evidence, or it is a consequence of intellectual laziness? Examples. Early psychosis, or psychotic symptoms in general population. My point is that Kraepelinian dichotomic taxonomy is confirmed and reinforced by Husserlian analysis of psychotic forms of consciousness. So this means that if you go for a Husserlian analysis of the subjective experiences of people suffering from psychosis, plural, the Kraepelinian dichotomy will be confirmed and reinforced. That's because clinical phenomenology, that is the discipline, the clinical discipline that derives from philosophical phenomenology, is a method to deconstruct the concept of unitary psychosis and re-establish clear-cut boundaries between schizophrenic and manic depressive disorders. I perhaps don't need to explain why this is relevant, but I will say it. First, how can we find biological correlates of something that is not properly phenomenologically defined, like psychosis? And how can we treat a condition that is not properly phenomenologically understood? Understood means to reproduce what it is like to go to have a certain experience and what is the personal meaning related to this experience. So, what is psychosis? The term psychosis is obviously over-inclusive since there are several forms of psychosis that can be phenomenologically differentiated. It's like the concept of ice cream. There are several forms of ice creams. It's like the concept of pizza. There are several types of pizza. It's like the concept of fish and chips. If I go here around the corner and they ask for fish and chips, they will laugh at me, as it happened a few years ago when I was spending some time in England. There are several forms of fish and chips, several forms of ice creams, and several types of pizzas. Although there is a real pizza that is Napoli pizza. This is the real one, not the other one. But I will not go into an essentialist discourse about what is real psychosis or real schizophrenia or real mania or real major depression. So what I suggest as the first move is to confine the term psychosis to design psychotic symptoms. And if we follow this way, we can easily say that not all forms of schizophrenia or manic depression are psychosis, since there are schizophrenic and manic depressive syndromes that are with or without psychotic symptoms. And second, not all forms of psychosis are schizophrenic or manic depressive syndromes, since there are other syndromes that include psychotic symptoms, such, for instance, paranoia, paraphrenia, organic psychosis, and the like. So, what's the point here? The point is that as a clinical phenomenologist, my main interest and job is to identify and define homogeneous and clear-cut phenotypes. And in order to show how this can be done from a phenomenological stance, how can the phenomenological razor, so to say, be used in the clinic of psychosis, I will use the example of differentiating schizophrenic delusions from depressive delusions. So, the general question is the following. Are psychotic symptoms in schizophrenia, mania, depression, paranoia, etc. identical or not? And can they be differentiated? And if they can, how can be differentiated? So, the phenomenological razor at work. I will talk about the case of delusions, one of the most known psychotic symptoms in schizophrenia and in major depression, and try to show that their phenomenal as well as phenomenological nature is deeply different. An analysis of delusions in these two forms of illness brings to the fore that they can be intrinsically differentiated, but also extrinsically differentiated. The intrinsic differentiation is about the different form of these two sorts of delusions in schizophrenia and major depression, where the content differentiation is about the themes that are involved in these two sorts of syndromes. But since it will be certainly boring and perhaps certainly for me too difficult to go theoretical about this, I will make you examples. Intrinsic features of delusions. What is the form and what is the content of a delusion and of a symptom in general? The form of a symptom is the way a given content is presented to consciousness and the relationship that this content has with the subject of experience. We owe this definition to Karl Jaspers. And I suggest that form is more diagnostic specific, whereas content appears more incidental and individual. We know from the clinic that the same content can appear in diverse range of phenomenological forms. For instance, a patient may have a long-standing preoccupation with illness presented in the form of an overvalued idea or in the form of persistent intrusive thought, even though the patient resists the intrusion and knows it to be false. This is the case of a compulsive idea. Or he may have the same content under the form of a sudden and compelling idea of being ill, and this is called primary delusional intuition. All these symptoms have the same content, let's call it hypochondriasis, but they are present in consciousness in different forms. And as you all know, an overvalued idea is not properly a symptom, whereas a compulsive idea it is, and it is sharply to be differentiated from a primary delusional intuition. So what about schizophrenia and depression? In schizophrenia, delusions have typically the form of revelation. The person is struck with something that opens up a new meaning, a new identity, and a new understanding of the world, which is, to the person herself, deeper and more personal. This is a quotation from Wolfgang Blankenburg, a German psychiatrist. From the second he saw it captured him, subduing him with its charm from which he could not unhook himself. This is the concept called by Conrad apophany, which means literally revelation. Whereas, what is the form of typical depressive delusions? They have the form of confirmation. The melancholic person, or the melancholic delusion, is structured as the confirmation of a point of view that the person already has of herself and of a judgment that is already implicit in her value system. This has been studied by Alfred Krauss, a psychiatrist from Heidelberg, who published since the 80s on this issue. So, on one side we have revelation, on the other side we have confirmation of a pre-existing identity and world view. What about content? Schizophrenic and depressive delusions can be differentiated according to content. In schizophrenia, we know since Jaspers that the content of delusion is metaphysical, or properly said, ontological. Metaphysical delusions, they display the concern to discover the essence of reality of which other people are ignorant. But you also have eschatological delusions that display the concern for the end of the world, or charismatic delusions. Charisma in Greek means gift, to be gifted, that display the concern to use one's own gift to save the world or mankind. On the other side, we know since at least Kurt Schneider that the content of depressive delusions is not ontological, but rather ontic, or ethical, if you prefer. And the main contents, the typical contents, are guilt, illness, and ruin. Guilt, the concern to have lost one's moral integrity. Illness, the concern to have lost one's physical integrity. And ruin, the concern to have lost one's financial integrity. This slide sums up the two differentiating criteria as regards delusions in schizophrenia on one side and major depression on the other. I've written some papers about this, just in case you would like to make some notes. It's not need, just ask me the paper and I will send it to you. It's published in Journal of Affective Disorders. Okay. So what about other criteria to be used as phenomenological razor to differentiate between delusions in schizophrenia and delusions in depression? There are at least 4 dimensions to be analyzed. The first one is the so-called preparatory field of experience. Then the background feelings, then the ontological framework. This is relevant about the life world inhabited by schizophrenic persons on one side and depressive persons on the other. And last but not least, values, or the existential orientation of these two different kinds of existence. What about the first dimension, the preparatory field of experience? This is the cognitive framework within which delusional experiences take place. And it entails changes in the meaningfulness of reality and of significance of one's own existence. In schizophrenia, and I'm talking here more exactly of the beginning of schizophrenia, there is an experience of latent meaningfulness. To the patient, reality is suspended between meaninglessness and the imminent revelation of a new meaningfulness. You may remember Jasper's patient. Something is going on. Please tell me what's going on. These are words from this patient. What is latent meaningfulness? It means that there is a loss of the habitual familiarity without a new kind of significance, or a disintegration of previous meaning patterns experienced as uncanny strangeness. So that understanding reality is not given for granted intellectual or cognitive apparatus. Rather, it has an achievement character. It has to be, understanding reality has to be achieved. As Peter Berner wrote, Peter Berner was a Viennese psychiatrist and psychopathology, has been also the chair of the World Psychiatric Association in the 80s. Patients are not struck by what people do or say, but what they don't do or say. So there is an inversion between the foreground and the background in the way these persons, schizophrenic persons, experience reality. And there is also a breakdown of Gestalt perception during which the neutrality of the background gets lost, as John Cutting, who is here, wrote in 1989. Completely different is the preparatory field of experience in depression. There is not a latent meaningfulness, but there is an experience of disunion that in German sounds with a quite awkward word, that's Verzweiflung. What is Verzweiflung? It is a disunion. Zwei means two. It is feeling divided into two parts. Okay, being teared apart by two different cognitive orientations. This term was used by Hubertus Stellenbach, another German psychiatrist based in Heidelberg, who applied this to the beginning of the melancholic decomposition, or the equivalent in a major depression of perplexity in schizophrenia. What is at stake here is the significance of one's own existence in an ethical sense, not the meaningfulness of reality or the existence of reality, as it is the case with schizophrenia patients. And we have to remember that Verzweiflung should not be simply understood as hopelessness, because it is a self-contradiction, to use the words of Tellenbach, a movement backward and forward, an alternation so that a definite decision is no longer possible. Sometimes we diagnose this as a panic attack, but really we have to learn phenomenologically how to distinguish a panic attack, that is a manifestation of acute anxiety, from this condition that is the gate from which people enter into an acute major depressive episode. There are mental ruminations, unfinished duties, or petite faute going round in the patient's head. And this has been established also by empirical research. There is a loss of perspective planning because duties appear one next to the other and not one after the other. So there is a breakdown of the rational agenda. First I do this, then I do that. All duties appear one next to the other, and then it is impossible to accomplish them and to surmount this. And this is clinically not so different, as I was saying before, from a panic attack, but this is only the what we can say at face value, because if we use the phenomenological razor, then we can identify that here the problem is not a neurotic anxiety, but is a deeper form of disunion and indecision that brings about the paralysis of action and of cognition that is typical of major depressive episodes. Another difference is about feelings or emotions. Background feelings are different in the beginning schizophrenia and in the beginning major depressive episode. This is, by background feelings, I mean the affective emotional matrix from which the cognitive changes that I described before arise. As with a philosopher, Matthew Radcliffe, who wrote a very good book about this issue. Background feelings are sometimes named existential feelings. And these feelings are the feelings that provide the existential orientation that operates as the pre-reflexive background to our experiences and our thoughts. Examples. One can feel familiar or unfamiliar in a given situation. One may feel participant in the world or as a detached observer. The world may feel real or hyperreal or unreal. All these are outcomes of different background feelings or existential feelings. And as we will see, in schizophrenia and in major depression, we have distinguished different ways of experiencing this background, emotional background. What is typical in schizophrenia that we know since Freud is the uncanny, unheimlich. It's right that Freud didn't use this term to describe the background feeling in schizophrenia, yet we must acknowledge that this is, we owe to Sigmund Freud great, very important studies about the meaning of this term, the meaning of this phenomenon. What is the uncanny? It is the quality of non-familiarity, or as Bruno Caglieri, an Italian psychiatrist and psychopathology, called it, the opposite of the Bekanntheit Qualität, the opposite of the quality of familiarity. It is the extraneousness from the world and from oneself, a feeling of premonition, of mystery, the opposite of taken for granted. And very close to this feeling of the uncanny is perplexity, or Ratlosigkeit, Störring, 1939, again a German psychiatrist. But whereas the uncanny is more an emotional, psychological phenomenon, Ratlosigkeit, or perplexity, was described by Störring as a disorder of motility. So an embodied form of abnormal experience. Words of Störring, paralysis of the body as the instrument for the discovery and the organization of experience. The patient is gradually becoming detached from external reality and undergoes feelings of strangeness, coloring the world with alien qualities. So this is a kind of derealization that brings about bewilderment and unsettles the patient, but at the same time promotes a powerful drive to a new understanding, the experience of revelation that we have found in the form of schizophrenic delusions. Quite a different story is what we found in major depression, because here the characteristic feeling is the feeling of the loss of feeling. What is the feeling of the loss of feeling? Is the painful experience of not being able to have any emotion. It is the painful experience of loss of emotional grasp and resonance. And this has been described by all, I would say, clinical phenomenology like Binswanger, Schulte, Tellenbach, and recently summed up by Berrios, who's not a clinical phenomenologist, but he wrote a very important history of psychopathology, as you all know. The first one who gave a sort of operational definition of feeling or loss of feeling was Schulte in 1961, and he defined it as the degradation of the power for having moods at all, as summed up by Anthony Fernandez, who is a American, very young American philosopher. You will hear about him in the next years because he's really very skilled. So the feeling of the loss of feeling is a paradoxical feature that mixes up a profound indifference but a painful, profound indifference. It is a paradox, because how can you feel painful for not feeling any pain? How can you experience in a painful way your incapacity of feeling? Well, we need to go to philosophy to explain this, and we need to go to the philosophy of Max Scheler and his description of different levels of emotional experience. And Scheler differentiates between vital feelings, and on this level, depressive persons are not able to resonate, but also spiritual feelings. And on this level, depressive patients can experience their incapacity of feeling on the vital level. So this paradox is perhaps one of the most striking and characteristic features, phenomenologically speaking, in major depression. And of course, this painful feeling of the loss of feeling aggregates with delusions of guilt, as we have demonstrated. So these people, depressive persons, feel guilty because they feel unable to feel. So there is a sort of a dynamic link between incapacity to feel and delusions of guilt, or if you want to put it more phenomenologically, the condition of possibility for certain guilt delusions in major depression is the experience of these persons who are painfully aware of their incapacity to feel. And this is, again, a summary of what I said until now, and let's go to the next two dimensions. I kindly remind you what I'm talking about. I'm trying to show you the capacity of the phenomenological razor to establish clear-cut boundaries between different phenotypes. Because phenomenology is not l'art pour l'art, but it is a discipline that is useful and perhaps indispensable to establish clear-cut phenotypes within the spectrum of major psychopathological conditions. So perhaps the most relevant field in which the phenomenological razor can help clinicians and researchers is by identifying the ontological framework within which each psychopathological experience is set. I understand that ontological framework may sound quite awkward as a term, but I will try to explain it as simple as possible so that even I can understand it, okay? So the majority of people are situated within a shared ontological framework, all of us. This is the implicit yet operative structure of reality. Yet, as Alfred Schutz, philosopher, German philosopher who moved to the United States, has shown, there is not only one common world for all of us, but there are several other frameworks of experience, like, for instance, fantasy worlds, the world of dreams, and, of course, psychopathological worlds. And clinical phenomenology argues for the fact that at least as far as severe psychopathological conditions are concerned, each psychopathological condition has its own framework of experience or ontological framework. Within each of these ontological framework, abnormal mental phenomena are the expression of a modification of the ontological framework itself, within which the experience is generated. And the overall change in the ontological framework of experience transpires through the single symptoms. But the specificity of the core is only graspable at a more comprehensive and structural level. And there is a lot of research going on here. We have, just to mention, the assessment tools developed in this direction, the examination of anomalous self-experiences by the Partners Group in Copenhagen, or the examination of the anomalous world experience developed by Louis Sass, Thomas Fuchs, myself, and others recently. And our group in Chieti, we developed several assessment tools to grasp the transformation of this ontological framework for schizophrenia, but also for so-called eating disorders. And we can talk about this, if you like, during the general discussion. So, what are the general guidelines to assess the ontological framework within which each of us is set? Well, this ontological framework is a structure, is a sort of scaffolding of our experience of the world. And this scaffolding is made of some dimensions. And these dimensions, the main dimensions are lived body, so how one lives his body, lived time, lived space, lived otherness, the way I experience myself in front of others, and selfhood. Of course, there are many others, but these are the fundamental ones. So if you want to describe and assess the life world of a patient, you need to develop tools that are able to identify the way this patient experiences time, experiences her own body, experiences space, experiences other persons, and so on. So this slide would need at least a seminar, but I use it just to show you the big difference between the ontological framework of schizophrenia and of depression. In schizophrenia, what about space? We have an itemization of space. So we could say that the persons with schizophrenia have difficulties in seeing the forest and they see single trees. This is something that we have found, and not only our group, analyzing first personal experiences in persons with schizophrenia. By the way, I want to say that I'm very grateful to John Cutting, who offered us his rich database about first-person experiences in people with schizophrenia, mania, and major depression that we are analyzing in the last 10 years. And little by little, we are producing papers on this. Whereas in depression, you don't have this itemization of space, but you have an experience of distanciation from the objects that appear out there in the world. The experience of time is also radically different, because in schizophrenia, and that we have demonstrated, we published this paper in Schizophrenia Bulletin a couple of years ago, the main characteristic is disaggregation. So there is an itemization of this time too. Whereas in major depression, we have a phenomenon called desynchronization. So my time, I experience my time and the time of others, the time of the world, as desynchronized. So there is not a disaggregation of a breaking down of the experience of time, but a desynchronization from my personal time and the time of the world. Also, there are different ways of experiencing the body. What we have found is that the body experience from the perspective of a person affected by schizophrenia is a body that is not only permeable, so that what is outside is experienced as inside, and what is inside is experienced as being outside. This is not simply a static phenomenon. For instance, if I were a person with schizophrenia, I would feel your head inside me, or my liver out there. We called the phenomenon that is characteristic dynamization. So the fact that I experience your head entering inside me, or my liver getting outside myself. Not statically. What is outside is inside, and what is inside is outside. But something that is ongoing. That's why we call this dynamization. Quite a different phenomenon we find in persons affected by major depressive disorder, because here we have a reified body. This is not the same as a mechanized body as we find in persons with schizophrenia. Persons with schizophrenia experience their body as a mechanism, an impersonal mechanism. Persons with major depression experience their body typically as something that is dead, as a thing, therefore reified. It becomes a res. Or as a psychiatrist and psychopathology Otto Dörr from Chile writes, a crematization of the body. And crema in Greek means corpse. So there is a body that is experienced as dead. And this makes a big difference, not only from normals, but also from persons who are diagnosed with schizophrenia. Because one thing is to experience my body as dead, and another thing is to experience my body as a mechanism. And another difference about the experience of the body is that one thing is to experience my body or parts of it as out there, as it is the case typically with persons with schizophrenia, at least, analyzing their first personal experiences. And quite a different thing is to over-identify with my dead body. That is the case with persons with major depression, or as John Cutting says, thisness or thatness. So the experience of major depressive people with major depression is an experience of thisness of the body, whereas the experience of persons with schizophrenia is an experience of thatness of the body. Okay. I gave you an example of what can be seen below the level of full-blown or flamboyant symptoms like delusions. So I don't need to show you the slide. That was a detailed description of difference in bodily experience in persons with schizophrenia. How many? I have to finish? Okay, I'll take 2 minutes more, just not to have depressive crisis or panic attack right now. Okay. So just 2 words about the existential orientation. there are different values in persons with schizophrenia and in persons with major depression. I will not say very much about this because some words are abracadabra and I will need to explain them in detail, but there are papers that I published on that and I can send it or we can discuss it later on. So I come to my conclusions. One thing, clinical phenomenology is a way to identify and define homogeneous and clear-cut phenotypes. We call them phenotypes, so phenomenological phenotypes. And knowledge about the patient's subjectivity or life world is for the psychiatrist like anatomy for the surgeon. So we need to have anatomical tables that are beyond symptomatological assessment, but they must lay on the ground of phenomenological assessment of the structures of the life world to create clear-cut phenotypes or phenotypes. Second, the phenomenological method is the know-how, the method for exploring the patient perspectives. And this is like a laser scalpel to the surgeon. The phenomenological method is to the psychiatrist like the laser scalpel for the surgeon. And I would like to conclude with this, saying that the title of my talk is a tribute to Pink Floyd. As you may remember, some 40 years ago, they published a record whose title was A Nice Pair. And I think that that was really a nice pair for all rockers remember and know very well that's what a nice pair. I hope that I gave you a flavor that Kraepelin and Husserl, their being splitters, they are a nice pair too. Thank you very much for your attention.